Welcome to my presentation on the topic of angiographic MRI of the placenta. My name is Oliver Wieben and I'm an imaging scientist at the University of Wisconsin-Madison. I would like to thank the organizers of the SMRI meeting to provide me with the opportunity to present this topic, and I hope you enjoy this virtual talk. I disclose that my institution receives research support from GE Healthcare. In this presentation, I will introduce the clinical motivation for placenta imaging and some essentials on the anatomy and physiology. I will review methods for the measurement of blood flow to the uterus with 2D PC and 4D flow MRI. I will also discuss the use of ferumoxetrol MRA for capturing angiograms and quantitative dynamic imaging for assessing perfusion and functional domains, as well as safety aspects. Finally, I will briefly review ASL perfusion methods and challenges in the placenta. The placenta has many roles, including the delivery of nutrients and oxygen to the fetus, as well as the removal of waste products. As such, proper placental development is crucial to fetal development and maternal health, as well as long-term health of the fetus through all of life. Inadequate placental development can lead to serious consequences for the mother and fetus, such as preeclampsia, gestational diabetes, preterm birth and growth restrictions, and even stillbirth. Despite its recognized importance, placental development is understudied, especially if it comes to monitoring of placental health in early stages of pregnancy, which is the most critical period of embryonic development. The NIH initiative, the Human Placenta Project, seeks to improve outcomes through the non-invasive assessment of placental health in early pregnancy. To that effect, MRI has a lot to offer in terms of anatomical and functional assessment. However, costs, availability, and challenges with data acquisition have hampered its use in the clinic and research. Challenges include the presence of maternal and fetal motion, dual circulation, lack of thorough safety studies, and reduced patient comfort. Here, we will focus on the use of MRA to assess vascular anatomy as well as flow and perfusion. The anatomy and physiology of the placenta is rather unique, as shown here: two uterine arteries, left and right, and to a lesser degree, the two uterine branches of the ovarian arteries supply most of the oxygenated blood to the. These vessels feed into the spiral arteries, which, in pregnancy, supply the blood that fills the intervillous space, practically bathing the placenta. Over the course of gestation, major vascular remodeling occurs and facilitates a drastic increase in the placental blood, driven by an increased flow in the spiral arteries and further upstream the uterine and ovarian arteries. The increase in flow to the uterus is dramatic, up to 10 or 12-fold above the non-pregnant state by term. Therefore, both macroscopic flow and perfusion measures are intriguing parameters for the assessment of placental health. Let's take a closer look at the unique vascular bed of the placenta. Note that there is no capillary system and the maternal and fetal blood never mix. Instead, the maternal spiral arteries supply blood into functional units called Cotyledons, which bathe the fetal vessels to allow the exchange of oxygen, nutrients, and waste. Blood flow to the placenta can be measured with Doppler ultrasound. However, it is considered inaccurate because of the presence of complex flow. Also, contributions from the ovarian stem arteries are not captured, while they contribute about 20% of the total uterine blood flow and possibly more depending on placentation site. 2D PCMRI has been used in a similar fashion. The additional capture of flow contributions from the ovarian stem arteries has been attempted. However, it was found to be unreliable because of the difficulty to locate these small and tortuous vessels. 4D flow MRI is an appealing alternative for the simultaneous assessment of vascular anatomy and Utero-Placental flow. In our approach, all data are acquired within a 10-minute free-breathing 3D radial acquisition without a contrast agent. This example from an early third trimester rhesus macaque shows a high-resolution angiogram with color-coded maternal and fetal vessels. The scan also provides velocity information for all the vessels in the large imaging volume, as shown here in form of velocity streamlines. Vessel diameters and length as well as flow can be recorded for many vessel segments. We initially developed and applied this technique in an animal study shown here as a color-coded MR of a third trimester rhesus macaque. Note that umbilical and fetal vessels are also captured. We found that the uterine arteries were always visible on 4D flow MRI, while the ovarian arteries were never visible. At least one ovarian vein was, however, visible in all of these datasets. The relative change in back-to-back flow measurements in the uterine arteries had a standard deviation of 17%. The following color-coded visualizations demonstrate the wealth of information in these scans. Here, the maternal abdominal aorta and vena cava, the uterine arteries, and the ovarian veins are highlighted. In the same data set, the uterine and placental structures are selectively shown. That includes the vessels in the umbilical cord, uterine branches, and fetal vessels. This third visualization concentrates on the fetal vessels, which includes the aortic arch and umbilical arteries. We also conducted 40 flow studies in human singleton pregnancies. Our subject population consisted of 20 healthy pregnant women, each scanned at 2 time points, 14 to 16 weeks and 20 to 22 weeks of gestation. We found that the flow contributions from the uterine arteries were reliably identified and fairly constant between 14 and 20 weeks of gestation. Meanwhile, flow from the ovarian arteries was less often detectable and increased from 14 to 20 weeks, both in flow volume and in number of detectable arteries. The Penn group used a more traditional Cartesian 40 flow sequence to measure flow in uterine arteries. They found modest agreement with Doppler, which cannot be considered a gold standard for reasons previously mentioned. Their study also highlighted the tortuosity and heterogeneity in the anatomy of the uterine artery during vascular remodeling, as shown here in the upper right. Now we're shifting gears towards contrast-enhanced MRA. Gadolinium-based contrast agents are unsafe to use during pregnancy. However, iron nanoparticles such as ferromoxetol are promising as they have shown to be effective in MRI and have been used to treat iron deficiencies during pregnancy. We pioneered the use of ferromoxetol for placenta imaging in non-human primate studies. In our protocol, DCE MRA volumes were acquired during the bolus passage, followed by a high-resolution contrast-enhanced MRA in the steady state. We've also investigated the capacity to detect inflammation, but this will not be covered here. This is an example of the contrast-enhanced MRA acquired with a 3D ultra-short TE center-out trajectory. You can appreciate the high isotropic spatial resolution of 0.5 millimeters in the rotating MIP achieved in less than 6 minutes scan time. Color-coded post-processing helps to distinguish the vessels. Here the uterine arteries and ovarian veins, as well as the 2 placental discs of the rhesus macaque are well visualized. During the bolus passage, we acquired 3D volumes with a temporal resolution of 5 seconds with the disco sequence. Here you see the time series visualizations in forms of a MIP to the left and an axial slice to the right, whose location is indicated by the yellow line on the left. Notice the slow enhancement of the placenta that starts at multiple small seed points in the cotyledons and takes many time frames to cover the whole placenta. Here you see these data formatted into selected individual time frames in the top row and the signal enhancement in 3 selected regions of interest for all time frames in the plot to the lower left. The green square represents an early enhancing region, while the blue circle represents a later enhancing region. It is remarkable that the late enhancing region lags by more than 30 seconds, demonstrating the extraordinary slow flow and perfusion within the placenta, dramatically slower than any other organ. Also note that no fetal vasculature is enhanced because no noticeable amount of ferromoxetol has crossed the placenta. The DCE data can be used to generate maps of contrast arrival and relative blood flow, as shown in the lower right. The group at the Oregon Health Science University developed a neat processing scheme to identify individual cotyledons from the DCE data using gadolinium studies. We adopted that algorithm for our ferromoxetol data using contrast arrival maps and watershed segmentation to identify individual perfusion domains that represent cotyledons. From this data, we can analyze the number of perfusion domains and their volumes. In a thorough safety study in the rhesus macaque, we assessed the fetal-placental unit and selected maternal tissues, pregnancy outcomes, and fetal well-being after ferromoxetol administration. We found that iron levels in fetal and maternal fetal interface tissues did not differ between animals with or without exposure to ferromoxetol, and there was no significant difference in tissue histopathology and no effect on placental hormone secretion. Arterial spin labeling, or ASL, enables non-invasive measurement of tissue perfusion by employing magnetically labeled blood water as an endogenous tracer. While very compelling, it is also particularly challenging in the placenta for numerous reasons. That includes the presence of maternal motion, such as cardiac, respiratory, gross body, and peristaltic motion, as well as fetal cardiac and gross body motion. The variability in geometry and presentation site, the presence of two circulatory systems, and the extremely long transit times in the slowly perfused placenta provide additional difficulties for current approaches. Further, the heterogeneity of the placenta suggests that volumetric imaging is more representative than 2D approaches, as shown in this multi-slice VSA-ASL scan. Pulsed ASL approaches have been proposed for placenta perfusion measurements as early as 1998. More recently, pseudo-continuous and velocity-selective ASL have emerged as promising approaches to address some of the confounding factors mentioned above. However, the sensitivity of these sequences to various imaging parameters necessitates additional studies before placenta ASL can be considered a quantitative tool. Especially the separation of maternal and fetal perfusion remains an obstacle in many approaches. Let's quickly summarize. I provided an overview of the unique anatomy and physiology of the placenta and various MR angiography methodologies to probe its vascular anatomy and function. That includes quantitative flow measurements with 2D and 4D flow MRI, contrast-enhanced MRI, dynamic contrast-enhanced MRI, as well as arterial spin labeling. Among others, the presence of two circulatory systems, the very slow perfusion within the placenta, and various sources of motion pose unique challenges to placenta MRI that call for innovative methodology development. While a small field, it is a rather active area as indicated by several recent program calls and formation of rapidly growing interest groups in society such as the ICMRM and SCMR. With that, I'd like to thank our placenta research team at the UW-Madison, as well as my funding agencies and you for your attention.